Good afternoon, everyone. Thank you very much for joining us. My name is Jesse Berg, and I'm a partner in the Minneapolis office of Lathrop GPM. And we are going to be talking for the next hour and a half or so about detangling the web, how healthcare providers can mitigate the economic impact of the COVID-19 outbreak. Joining me today will be Randy Schultz from our Overland Park office, Denise Block from our St. Louis office, and Julia Ryland, who is with me here in Minneapolis. This is the agenda that we're hoping to cover today. As you will see, we have a fairly substantial set of materials to present. A lot of this is for your reference. If we don't get to something important and you'd like to talk about it afterwards, you are welcome to email any one of us at any time. We'll also be taking questions at the end of the presentation, and you're welcome to submit those via the chat function at any time during the program. I'm going to start things off by talking a bit about some of the regulatory and reimbursement developments for healthcare providers as a result of the CARES Act. I'll turn it over to Randy, who will pick up and talk about the Paycheck Protection Program, economic injury disaster loans, and other materials as well. Denise Block will then pick it up and talk about what's happening with the Medicaid program and various additional sources of funding. And then we'll turn it back over to Julia, who will discuss some of the public health system challenges and responses and potential future changes at the federal level. The big news today, of course, is that this morning, the Department of Health and Human Services announced guidance related to distributing $30 billion directly to healthcare providers. And we are going to be talking about that as well. So just as a bit of level setting, this slide outlines the time frame for the COVID crisis, and you'll see things have escalated fairly quickly between China announcing the cluster at the end of December and the Health and Human Services Department declaring a public health emergency at the end of January. This slide here shows where we are in the country currently as far as stay-at-home orders, and you'll see that the dark blue states indicate all states where stay-at-home orders are currently in place. One of the challenges in addressing the COVID response is that there is such a fast flow of information, it can be difficult to keep track of it all and stay on top of what CMS and all of the other agencies are doing. This slide here outlines a few links to materials I found to be particularly helpful during the course of this crisis. There are descriptions of the various items and then links to websites where you can go to find some of these materials. The one item on here that is not a link is a reference to a set of regulations that were published on April 6th, an interim final rule implementing the CARES Act. And this is one of the most impressive sets of rulemaking I think I have ever seen. CMS acted extremely quickly to get these materials out. The pre-publication version of these regulations came out just 3 days after the CARES Act was passed, and this set of rulemaking makes the most wide-ranging and significant set of changes to telemedicine reimbursement under the Medicare program since Medicare first began paying for telemedicine back in 2000. And so we'll talk about that as well. But the big news this morning has to do with the Public Health and Social Services Emergency Fund. The CARES Act itself allocated $100 billion for healthcare providers under this program, which was set up back in 2005 in response to Hurricane Katrina. This is part of the Health and Human Services Department. It's administered by the Office of the Assistant Secretary for Preparedness and Response. And the $100 billion that's found in the statute is the biggest pot of no strings attached money available for providers. It's available across the provider spectrum, and it caught everyone's attention given the scope of the potential payments and also the lack of detail in the statute. This slide summarizes briefly the statutory guidance related to how the $100 billion would be allocated. But as you can see from reading through, there was not much guidance, not much specific information for providers to rely on. So what started happening earlier this week is that the administration began to give some hints as far as what they want to see happen with this $100 billion. Beginning on April 3rd, they announced that they want to devote a portion of it to covering hospital costs for treating individuals who do not have health insurance. Kaiser Family Foundation followed a few days later with a report indicating that if the money is devoted for that purpose, that would take up about 40% of the $100 billion in money allocated under the program. There's been a lot of pushback from the provider industry on various issues associated with this money, and we'll come back to that a little bit later. But on April 7th, Seema Verma, the administrator of CMS, gave a press conference and discussed her intent as far as how the program was going to work. And you can kind of see that description at the bottom of the slide here. This is intended to be direct deposits into provider bank accounts, no strings attached with the money. The providers would be able to use the money for whatever they wanted. And what we saw today then finally is actual guidance that came out from HHS as far as how this funding will work. The payments are starting to be made today. They've already hit certain providers' bank accounts. It's happening via direct deposit. All qualifying entities will receive this money based on Medicare fee-for-service payments from 2019. Payments are being made to taxpayer ID numbers, and there are certain commitments. It's not quite a no strings attached program. The big one is that recipients have to agree not to seek collection of out-of-pocket payments from COVID patients that are greater than what the patient would have been required to pay if they were treated by an in-network provider. So this is the surprise billing concept that the administration has been talking about over the past few years. The money will actually be paid before providers have to agree to these requirements, but within 30 days, they're going to need to file an attestation with CMS in which they agree to follow these guidelines. If a provider does not want to follow the guidelines, you will have already received the money, which means that you would need to go through the process of returning the money to HHS. United Health Group from Minnesota is handling the administration, so the payments are actually coming from Optum Bank with HHS payment listed as the payment description. The guidance that came out today explains how the calculation will work. And basically what's happening is that there's a formula for calculating the amount where providers' 2018 fee-for-service reimbursement will be divided by 484 billion, which is the total amount of Medicare reimbursement fee-for-service in 2019. And then you would multiply that ratio by 30 billion. So Health and Human Services gives an example of a hospice or a hospital that was paid $121 million in 2019 under the program. The hospitals would get $7.5 million. And the guidance gives a few different examples of how the payments will work for various kinds of organizations, including large systems, employed physicians, and physicians in group practices. So for instance, with physicians in group practices, they are unlikely to receive payments directly since they're not actually billing for the services themselves. Instead, the payment would be made to the group practice, and the providers would need to look to the organization that bills Medicare to identify the details as far as the portion that reflects the physician work. Now, this is 30 billion of 100, which means we still have $70 billion left, and it's not entirely clear what's going to happen with that money. But the guidance that came out today says basically that the remaining $70 billion will be distributed to providers with lower share of Medicare payments. For instance, those who predominantly serve Medicaid populations or uninsured individuals. But as I mentioned earlier, the administration has already said that a significant portion of the $100 billion will go to hospitals that cover uninsured individuals, so it's not entirely clear how this will work. The public health services funding is not the only source of revenue from the CARES Act, of course. Another large and important part of this statute is what's called Medicare's Accelerated Payment Program. Now, this isn't quite as catch-free as the grants I just talked about, because these are basically loans. But the good news is CMS is acting very quickly through their Medicare administrative contractors. The MACs are processing requests and are generally responding within 4 to 6 days of receiving a request. They've so far paid out more than $51 billion under the Accelerated Payment Program. And this basically permits providers and suppliers the opportunity to request up to 100% of Medicare payments over 3 months or 6 months if you're a hospital. And if you're a critical access hospital, you can get 125% of your Medicare reimbursement over that 6-month period. Now, this money does need to be paid back, but it is there as a way to try to help providers as they move forward through this crisis. A number of additional changes as well. Everyone in the country was supposed to be hit with a cut in Medicare fee-for-service reimbursement related to the sequestration program for a few years back. That has been put on hold for the time being. CMS has also done a lot to relax the requirements of national coverage and local coverage determinations. So these are the guidelines that indicate what kind of conditions, diagnoses, for example, that patients need to have before Medicare will cover a service. And what's happened with our NCDs and our LCDs is that the CMS and the MACs have basically taken away some of the restrictions that would normally apply that would permit or prohibit reimbursement for being made during the time frame at issue. Many other changes as well. This slide here outlines some of the payment opportunities available for hospitals, for clinical labs, durable medical equipment companies, for example. There's an additional $1.32 billion under the Public Health Services Act that's already been paid out in large part to federally qualified health centers and other community health centers. Hospitals are getting a 20% addition in their DRG reimbursement associated with patients who are diagnosed with COVID. And then you can see some of the other changes for certain provider and supplier categories as well. In addition to the reimbursement requirements, CMS has done a lot to try to reduce regulatory restrictions. This began on about March 13th with the issuance of what are called nationwide waivers or blanket waivers. You may have heard the term 1135 waivers, and that's basically just referring to the section of the Social Security Act that permits the Health and Human Services Department to reduce regulatory barriers in the event of an emergency. And these are all in the statute. We'll be talking about a few of them in specific detail going forward. But this is how CMS sees things. This slide comes from CMS itself, and it illustrates what they believe they're doing to try to help providers. So the themes here, as you might be able to tell, are things like keeping patients away from having to go deal with in-person visits, reducing barriers to remote care, and removing regulatory burdens, or at least minimizing them. And so this is happening in a variety of ways. One of the ways that it's happening has to do with the quality-based or value-based reimbursement that most providers need to meet these days. So the general rules are that providers are being required to report in on performance or quality metrics, and if they don't hit defined targets, they can see a cut in their reimbursement for the next year. So for instance, physicians paid under Part B were scheduled to get a 5% cut in Medicare reimbursement. So instead of 100% of the physician fee schedule rate, you would get 95% of the physician fee schedule rate if you didn't hit the quality targets at issue. But in recognition of the challenges to quality reporting resulting from COVID, what CMS is basically saying here is we're either going to hold providers harmless if they don't hit the quality targets, or we're going to say that you don't even need to report at all, and that way you won't be penalized for doing the kinds of things you're trying to do to deal with this crisis. And it's not just for physicians, hospitals, skilled nursing facilities, many other categories of providers and suppliers outlined on this chart are getting the same benefit. Other changes include significant simplifications to the Medicare enrollment process during the emergency. I won't go through a lot of these. I will just say I've never before heard of the concept of enrolling in Medicare via a phone call, but that's one of the options that's available in certain circumstances for the time being. Many other changes as well. A delay in having to file cost reports, for instance, a delay in reporting obligations under the Open Payments Program, which is the Physician Sunshine Law, is another flexibility that CMS is giving providers. And then this last one here, this one is actually permanent, which is kind of interesting. But really what's going on now under the CARES Act is that there's a recognition that providers who are subject to HIPAA and who also have obligations under the Federal Substance Use Disorder Confidentiality Law, which is known as Part 2, have been subject to significant challenges in trying to reconcile those laws over the years. And what the CARES Act does is it makes permanent changes to the Part 2 regulations that are really intended to bring them more in line with HIPAA. So use of substance use disorder treatment information will be able to be shared for treatment, payment, and healthcare operations purposes in the same way that protected health information can be shared under HIPAA based on consent. So this is intended to be helpful. The trade-off for reducing some of the barriers for complying with confidentiality of substance use disorder records is that there's a new prohibition against discriminating against patients in treatment and employment, housing, access to court, government benefits who are receiving treatment under the substance use disorder programs. I could spend easily half an hour talking about all of the different regulatory flexibility options CMS has made available for different provider and supplier categories. But if you can go to the link on this slide here, you'll be able to find super helpful cheat sheets. They run anywhere from 2 pages to 15 pages, depending on the provider supplier category at issue. And they go through and explain in great detail about some of the rules CMS is relaxing for various types of providers. So this slide and the following slide here outline some of the changes that CMS is making to try to make things simpler for providers. Home health agencies, under CARES, we're seeing a significant expansion in the ability to use home health agencies for patients. For instance, the requirement for home health agency reimbursement that patients be homebound, that's been relaxed based on the CDC guidance that suggests that older Americans stay home to deal with the COVID crisis. CMS has also taken steps to address reimbursement under the Medicare program of COVID-related services, and also obligations outside of the Medicare program for providers who render diagnostic testing, and obligations for group health plans to pay those providers at the negotiated rate or the provider's publicly available cash price for the service at issue, and providers are required to list those cash prices. Telehealth, probably the biggest winner under the CARES Act. There's a significant expansion of telehealth reimbursement, both under the statute itself, and some of those changes are listed on this slide here, and then under the final regulation that I mentioned a minute ago that came out after just about 3 days. So this is really a remarkable rewrite of the payment rules for telehealth. So much is happening here, it's kind of stunning. Basically, CMS is saying telehealth can be furnished to patients wherever they are located. Reimbursement is being rewritten from the previous rules that tended to pay at Medicare's lower facility-based payment rates and flipped so that they would be paid at the non-facility rates in the same way that a physician would be paid if he or she did an inpatient visit in the physician's office. So providers will be paid more for services rendered by a telehealth. There's also a significant expansion of the services that Medicare will cover through telehealth. 80 additional services are going to be covered as a result of these changes, and many other changes as well, including the ability for physicians to provide direct supervision, both in hospital-based and in freestanding locations through telehealth technology. So that is a significant reduction in regulatory barriers for providers. And then also specifically saying that the smartphones, the iPhones that we all have right now, those can meet the grade as far as Medicare's requirement to have interactive telecommunication systems that you need to have telehealth reimbursement. So these changes currently are temporary, but it really makes me wonder if that's going to last, because the issue here is that once patients, once payers, once providers get used to rendering care in this setting, it's going to be very challenging for CMS to unring the bell and go back to the old rules. Academic healthcare providers have seen some significant improvements as well, basically permitting teaching physicians to use telehealth to supervise residents, providing all levels of outpatient evaluation and management codes, not just our low and mid-level services, can be provided by residents with teaching physicians supervising remotely. changing the rules so that moonlighting residents, so that reflects residents who provide services outside of their graduate medical education program, have more flexibility to provide services. They'll now be able to do so on an inpatient setting. Previously, they could only serve patients in an outpatient or emergency department setting, and then also more of an opportunity for teaching hospitals to claim residents under their direct and indirect GME payments during the crisis. I mentioned the coverage relaxation requirements earlier, a few other changes from the CARES Act are outlined on this slide as well. And then the last thing I'll talk about before turning it over is we've also seen a significant relaxation of the regulatory rules under the Stark Law and anti-kickback statute that are intended to make it easier for providers to render care. So CMS has put out a series of waivers of the Stark Law that basically say they will protect payments between physicians and entities to which those physicians make referrals for designated health services, so long as the payments and the referrals are solely related to COVID purposes. And the slide here outlines the specific COVID purposes at issue, and they're intentionally written in a broad way, trying to create flexibility for the providers. There are 18 separate streams of remuneration that can be waived, and you can see some of those on this slide here. This includes things like paying providers more or less than fair market value for the services that they render, leases of a space or equipment that are below market rates, loans that are on favorable terms, more favorable, for example, than a provider would be able to get at a bank, for instance, and then a series of other waivers as well. Office of Inspector General, which enforces the anti-kickback statute, has taken similar steps. They issued a policy statement indicating they won't impose sanctions under the anti-kickback law for anything protected under the Stark Law waivers. And then the OIG has put out a few other pieces of guidance, including a statement from leadership that basically says that they will consider the context and the intent of parties engaged in conduct currently to deal with the COVID crisis in analyzing that conduct under the anti-kickback statute. And then finally, what's almost like an accelerated advisory opinion process, OIG will put out advisory opinions that gives its interpretation of anti-kickback risks, but it's a long process, it's slow, it's a little bit challenging to work with. But now what they're starting to do is issue frequently asked questions that are intended to help providers get answers on a much more expedited basis. And the one they've put out so far addresses providers who want to furnish services for free or at reduced costs to assist long-term care providers with staff shortages. OIG looked at that and they said, you know, we think low risks of fraud and abuse, so long as the services offered meet the requirements you see below. And the requirements there are pretty straightforward, pretty simple. So I think this will be very helpful for providers as well. So with that, I'm going to turn it over to my partner, Randy, from Overland Park, Kansas, who's going to pick things up and talk about a few more developments under the CARES Act.
Thanks, Jesse. Appreciate that very much. We have clients all over the country who have become very scared, obviously, because of the economic situation. Everybody's trying to obtain any type of financial assistance they can receive. Unfortunately, information that all of you are receiving from banks and other commentators have tended to conflict with each other. As you know, the government changed the PPP loan application 3 times within the first 48 hours that they had issued it. Of course, the good news is that with the big payments that are flowing in right now, I'm hoping many of you are receiving emails or texts on your phones from your banks or from your office administrators or practice managers, whatever it may be, that you're getting these deposits into your bank accounts. I know I've been receiving messages about this fact from clients this morning, turning this holiday even a happier time. 70% of all small businesses have already applied for these loans, especially the Paycheck Protection Loan. So many of you may have already applied for your loan, but what I want to focus on is give you a little background about what kind of money is available, and then look at specifically who is eligible for the Paycheck Protection Loan, how much can you possibly get, And then once you determine how much you can get, how much is available for your forgiveness or for the forgiveness of the loan, and then what determines whether that forgiveness is going to occur. And that's where the real planning comes in when you're looking at this information. I mean, it's pretty easy to decide how much you're going to get. We'll go through that calculation in a second. But then the question becomes, of what you receive, how much is eligible for forgiveness? And then what are the strategies you can use to best utilize that cash flow for the benefit of your organization, but yet still fit within one of the forgiveness provisions? So, and I can see we've got a little bit of an issue with the slides, but I'll start off by saying that there's the economic injury disaster loan, which is possible to be obtained. That loan, if you're eligible for the loan, and that's subject to size and income requirements, can be added on top of the amount of payroll you receive for your paycheck protection loan, so that you can then have the combined total, the economic injury disaster loan and the paycheck protection loan, all forgiven. So we've got clients trying to obtain both types of those loans, and I'll touch on that in a little bit. The CARES Act also provides loans for individuals and employees, and provides various types of benefits that the employer can utilize to leverage their financial situation. We've been telling clients to try to utilize a combination of unemployment compensation benefits plus the expanded $600 a week benefit that the government's provided through the end of July in combination with the paycheck protection loans, so that you can stabilize your cash flow. And that's why it's so important to understand these forgiveness provisions we'll talk about in a few minutes. The federal government also allows businesses to obtain tax credits of various types. I'm not going to go into the detail of the tax credits. The important aspect of the tax credits is that they may conflict with your ability to obtain paycheck protection loans. So if you've got an advisor that's telling you to utilize both all of the full range of tax credits and the paycheck protection program, there may be a conflict. An important thing for everybody to understand from a planning perspective is that even if you cannot obtain forgiveness of your loan, the loan is still a good deal. So if I'm in a situation where I need to have access to funds, and I don't want to use all those funds just for payroll because I have to keep my doors open, even if you use the funds for non-permitted purposes, you may not get forgiveness, but it's still a 2-year loan at 1% interest that you can pay back at the end of 2 years. And because you're using the proceeds of the loan to pay other expenses that are likely tax deductible, whether it's rent or any other kind of expense you've got to pay to keep your doors open, you'll create a net operating loss. And the federal government has created new provisions for net operating losses that you can carry those forward. So at the time you have to repay your loan 2 years from now, you can use those net operating losses created today, carry those forward, and offset the income necessary to repay that loan. So for all practical purposes, you're paying back the loan with pre-tax dollars. No, it's not quite as beneficial as a grant, as essentially the Paycheck Protection Program would be, but it's still an excellent way to maximize your cash flow, keep your doors open, and yet get the benefit of this act. Let's get into the Paycheck Protection Program itself and how it operates. The Paycheck Protection Program loans come directly from your bank if your bank has historically participated with the SBA program. The economic injury disaster loans have to come directly from the SBA. And I think you'll all see that it's much easier dealing with your lender than it is the SBA, although again, many lenders across the country have either misinterpreted or maybe we'll say not interpreted many of the provisions of this Paycheck Protection Act, and they've had difficulty or unwillingness to process loans. But we think those issues are being straightened out across the country very quickly. So I think your local lenders will soon be able to process these loans more effectively if they haven't processed it already. And remember, the law says that once you're approved for a loan, and I assume many of you may have already been approved for a loan, the law requires the bank to fund that loan within 10 days after the date the loan is approved. And as soon as you receive the money, that's when the 8-week period begins with regard to uses of the funds and forgiveness of the funds, which we'll touch on in a few minutes. Let's go to the next slide. Okay, who are eligible borrowers? I'm spending a considerable amount of time with clients determining who is an eligible borrower. If you're a small employer, which most provider groups would be, with not more than 500 employees, you're going to be eligible for these paycheck protection loans regardless of your income levels. If you're a small hospital or a potential large practice of some type or some type of affiliated practice, you come real close to hitting that 500 employee level. You also have to be in operation on February 15, 2020 and had W-2 employees or 1099 independent contractors. What's really critical, though, is that you've got to be able to determine, do you have to affiliate with someone else or another organization that has an ownership interest in the entity that you are operating. Now, the government recognized this issue, and they made, next slide please, they made special adjustments for organizations within the accommodation and food services business industry as defined by NAICS Section 72. So in other words, all the restaurants and hotels out there that have different locations, they count 500 employees per location as opposed to an aggregate number of employees based upon the total number of employees the national entity may own. Unfortunately, this per location test doesn't apply to any organization other than an organization listed under NAICS Code 72. Certain franchise businesses, we go to the next slide, or certain businesses that receive financial assistance from a company licensed under Section 301 of the Small Business Investment Act. The critical issue when it comes to affiliation is that the SBA Section 121-301 says that any organization that has 50% or more control over another organization, either by stock or simply by other means, will create an affiliated organization, so you have to combine the organizations together. Guidance came down this week that said that if you are in a control position from an equity perspective, that you've got documentation that shows that that owner of the majority position does not have control because of documentation, or I should say the ownership of controlling position does not have control because your corporate documents take that control away, then control may not exist for the affiliation purposes. These tests of affirmative or negative control are subjective tests by the SBA. So if you're an organization that's close to the 500 employee level and there's someone that either owns you or controls you, you got to be careful about whether you satisfy the eligibility requirements of these loans. For example, we have a large nursing home client that has many more than 500 employees, but part of what they do is they manage and operate individual nursing homes that are owned by, say, a mom and pop nursing home where a husband and wife may own a nursing home, but it's managed by the big national company. The law says that if it's managed by, the small entity is managed by the big national company, the small entity will be deemed affiliated with the larger company, and therefore you're considered one entity. How much can we get? Next slide, please. We know that we can receive up to $10 million in loans. The mathematics are 2.5 times the average monthly payroll costs incurred in the 1-year period preceding the loan date or the average payroll cost for calendar year 2019. Now, this measurement stick of calendar year 2019 is not in the law anywhere. That's just something that they've implemented to make an accommodation to people performing this calculation. And what you're going to find is there's multiple provisions under the law where there's accommodations that are made that aren't directly described in the act, and that's part of the problem the banks are having when they need to determine who's eligible for payroll. We received the question, what does payroll mean? Payroll costs, next slide please, means salary, wages, tips, family, sick leave, PTO, and the normal costs you'd consider being payroll. However, you cannot include the wages of anybody making more than $100,000. One of the confusing points across the country has been whether the $100,000 is a limit just on salary or whether it's a limit on salary and benefits together. And the law is that it's just a limit on salary. So compute your salaries up to $100,000, add the employee benefits on top that are permitted, the health insurance, the retirement plan benefits, and that's how you receive your mathematical average that you multiply times 2.5. As you can see from the slides, there's certain other elements that are considered in the computation, but the amount specifically excludes the 2-week payments required under the Families First Coronavirus Response Act. That's the $511 per week for individuals who are quarantined or are sick, or $200 per day for individuals who are taking care of a family member. Those expenditures in that special provision are excluded. Now, as healthcare providers who are on this call, healthcare providers and people who work for them are excluded from that special payment. But it's important you understand that those payments are not usable under the Paycheck Protection Program. Next slide, please. How do we use the funds? Okay, you obtain the amount of money you determine the amount of money you can obtain based upon 2.5 times qualifying payroll. Then the question becomes, how much of these funds are available to be forgiven? You add up all of the expenditures you make during the 8-week period following the date of receipt of the loan to determine how much of your loaned money is eligible for forgiveness, which includes payroll costs, benefits, salaries, rent, utilities, other typical issues. There are certain other specific uses that can be performed, but if you use the funds for purposes outside the permitted uses, those funds used for non-permitted purposes are not subject to forgiveness. And that's very important. We want to maximize the use of these funds for purposes of forgiveness. Now, again, as I said before, if you have a situation where you need to use the funds for non-permitted purposes, that doesn't destroy anything except your ability to obtain forgiveness on those funds. It may be your best business move to use these funds for non-permitted purposes because nothing prohibits you from doing that. Using funds for non-permitted purposes would simply prevent you from receiving forgiveness of debt on that source of funds. Next slide, please. The general rule is that the interest rates cannot exceed 4%. As you all know, it's a 1% loan. There are no personal guarantees, no collateral. If a balance remains after the forgiveness period, the maximum maturity is for 10 years. The initial payments for principal and interest can be deferred for 6 months, and that's what they're going to let you do is defer for 6 months. But you just got to make sure that you're acting in good faith. We have heard reports of a lot of people getting money where their businesses have not been impacted by the COVID-19 or have made other representations that weren't accurate, and the government's already stated they're going to form their own task force to go after people who are not acting in good faith. Next slide, please. The forgiveness amount is determined by looking at the total amount that was expended during the 8-week period of time following the time the loan was received, and comparing that to the number of individuals who were on your payroll during that 8-week period of time. The test is basically a three-part test. Part number one, you look at the average number of employees you had during the 8 weeks following the date you received your loan. You compare that number to the average number of employees you had between February 15th, 2019 and June 30, 2019. You compare the averages. And if the average is the same, you satisfy the FTE portion of that test. The second part of the 8-week test is determine whether or not you've paid, on average, at least 75% of the compensation to your employees during the 8-week period of time that was paid back between February 15th, 2019 and June 30, 2019. The difference is, if you pay less than 75% of compensation for any individual employee, the amount you paid less than 75% reduces dollar for dollar the amount that can be forgiven. The next test, though, is the one that's caused a lot of confusion with people, and it still hasn't been developed that well. And it says, when you read it literally, that notwithstanding the average number of employees during the 8-week period of time, or notwithstanding the cash that was paid out for compensation in that period of time, if on June 30, 2020, you compare the number of employees that you have employed compared to who was employed on February 15, 2020, and you have the same number of employees employed, and you pay the same amount of compensation as you did on February 15, 2020, the loan's going to be forgiven to the extent you're using money for appropriate purposes during the 8-week period following the date you receive your loan. Example, let's say you obtain your loan on June 1. If you can satisfy the criteria on June 30 as having equal employees and compensation as on February 15, 2020, your loan's going to be forgiven so long as you make qualifying expenditures for the 8-week period of time following the date you receive that loan. Next slide. The government has stated that you've got to use the loan proceeds to pay for salaries. So 75% of your proceeds need to go toward salaries. That's not in the CARES Act. Like I said, there's a 1% interest rate. It's 2 years from the date of the loan you have to repay the loan, but again, that's not in the CARES Act. And as of yesterday, there are approximately 400,000 loans that have already been approved, with many more anticipated. But interestingly, very few of the loans have been funded. But we expect over the next 2 weeks a lot of that funding to occur. Next slide. Because of our time constraints, I'm not going to go into detail on the Economic Injury Disaster Loan Program. If anybody has questions, you can contact us. We can give you more information on that program. And at this point, I'm going to turn these slides over to Denise Block.
Thanks, Randy. All right, I'm going to be talking about the state Medicaid and the Children's Health Insurance Program waivers. This is just a little bit of the background. Again, we've already heard about the Medicare waivers from Jesse. There have been waivers related to the Medicaid provisions. The states have had to individually apply for them in order to better meet the needs of the Medicaid enrollees in the various areas. And just for an example, pretty much almost all the states have now received, applied for and received waivers. The waivers vary somewhat between states. However, there's some specific areas which they've really received relaxed requirements so that they can better serve the population. And what I've done, I won't go into any deep detail, but just to give you an idea of the different states that have already received these waivers. And again, these are for Medicaid enrollees. They've relaxed, for example, under provider enrollment, the screening requirements so that they're not as stringent and allow quicker enrollment. of the providers who can service the needs of the beneficiaries. The deadlines in order to revalidate providers has also been postponed so people can continue taking care of the beneficiaries rather than having to worry about getting credentialing in. They're now allowing out-of-state providers who have equivalent licensing in another state to provide services in different states, which allows those out-of-state providers to give care in the states where the emergency is going on to Medicaid enrollees, because you're seeing physicians, as for example in New York, where they've had calls for additional help. People from other states are able to go in there and help in terms of providing services. They're also, the provider enrollments allowed an extension of where services can be given as far as different settings, including some facilities that weren't previously licensed. We're going into some of the other waiver provisions that have been relaxed. The prior authorization for services, for example, rather than having to wait for the prior authorization to give certain fee-for-service care, the prior authorization requirement's been suspended so that the services can be given. Similarly, if there's already a pre-authorization for fee-for-service care, the providers are required to extend the prior authorization so that they can continue to give care. In an area of appeals, where let's say an enrollee has been denied, they can now get their appeals through the process quicker. Similarly, managed care enrollees can bypass their health plan appeal portion and can go directly to a fair hearing to keep the process moving and to get everyone the care that they need and want and deserve. Some of the other provisions, long-term care services and support, the pre-admission screening and the annual resident reviews have been suspended, and the level 2 reassessments that need to be done at 30 days have also been impacted, and authorizations for the minimum data set authorizations for nursing facilities and skilled nursing facilities have been extended. There's some other reporting deadlines and oversight that are also being allowed. For example, AIDS supervision requirements for home health, the OASIS and the minimum data set assessment and transmission, and supervision of hospice aides by registered nurses. The state plans are also able to go in and get amendments to their plans. They've modified the deadline for the states to be able to submit those requests. In former time, there was more, the public notice has been changed as far as what those state plan amendments have to do. So they're being given a lot more flexibility in their ability to make modifications. And also dealing with tribal issues, the consultation time for submitting emergency state plan amendments has been changed. We're taught under emergency preparedness and responses, there's home health and community-based services that are also getting waivers, including anything from being able to establish hotlines, increasing the people that they're able to serve, going through, emergency person-centered service plans, getting qualified for the pool of providers, and just a lot of extensions in terms of being able to provide those services to the community. And under the emergency preparedness, I'm not going to go into any deep detail so we can keep things moving along. The CHIP state plan amendments have also been changed. CMS has made it easier for the states to go in and submit amendments in order to make adjustments to their enrollment and their redetermination policies, as well as cost sharing requirements for children and the families who are living in the disaster areas, which is, pretty much everywhere. The template for the states to apply is streamlined, and there have been a lot of adjustments. The cost sharing requirements are reduced, and the whole process is moving more quickly. uh, state plan amendments in terms of some of the things that they've moved to do involve a variety of services, whether it's dealing with the benefits that are being provided, financing and reimbursement, prescription drugs, plan premiums, and that varies from state to state, which the key thing is that the states are going in and able to perform services much more quickly for the enrollees. The Family First Coronavirus Response Act, also Randy touched on this, and also it's federal medical assistance. It's going to be helping the public and the providers in getting increased funds to give services. And some of those services for COVID are including things like the vaccine, specialized equipment, therapies. Any states or providers that are receiving funds from the states can't impose deductibles, co-payments, co-insurance, or other cost sharing on the COVID testing services and treatments, and the requirements that Medicaid beneficiaries should receive this continued coverage until the end of the emergency. So in order for the states and the states to receive these funds, they have to agree to keep the beneficiaries enrolled, and they're only can terminate individuals if they voluntarily request termination of their coverage, or if a beneficiary leaves the state is no longer a resident. There's some also talking about some of the other things Randy talked about. There's been lots of money available for providers, states to seek funds under the CARES Act, but there are also a lot of other programs, and I'm just going to touch on these lightly. There are many more, but just to give you an idea of some of the resources available. The CDC, of course, has money. They're funding for prevention and preparedness and response related to COVID. They have grant management, and they're awarding funds, and they are continuing to do so. The Coronavirus Preparedness and Response Supplemental Appropriations Act. There's a national special pathogen system, and they're going to be awarding additional funds which is going to be going through both healthcare coalitions as well as hospital associations. So it's going to be important to be aware of that, because there's more money out there, again, to help those hospitals as they meet the needs. And there's HRSA has funds, which they're also providing to grantees. HRSA's mission is, of course, to improve healthcare with access and quality, with best practices, and to eliminate healthcare disparities. And they're operating where they're giving supplemental funding to various health clinics and health centers for the coronavirus preparedness and response. There's a application link on this form. There's also FEMA has money, which in conjunction with the Corona Task Force from the White House and HHS, they're also helping and working with states, local, tribal, and territorial governments to respond to the virus pandemic. There's public assistance that's available, and they're making it easier for recipients to access and get funds. There are other potential, just a couple examples of other sources in the federal government where there are funds for programs, whether it's with SAMHSA, there's funding, of course, for community behavioral health services, suicide prevention, substance abuse, and mental health programs, which are during this situation have been seeing a huge influx as people are isolated. There's a need for more assistance. And CMS also has funds to help the nursing homes with their infection control and to prevent the spread of COVID within those nursing home facilities. Some of the other sources, in addition to the federal funds and programs. Some of the states have instituted and are continuing to provide resources. For example, the Kansas Hospital Association's applied for an ASPR grant, which are going to be able to make funds available to hospitals, hopefully by early May. Hospitals will have to provide documentation reports to receive the funding. Minnesota has instituted several programs, two of which are the Small Business Loan Guarantee Program, as well as the Small Business Emergency Loan Program for Minnesota businesses. Colorado has a COVID Relief Fund, again, to allocate funds based on prevention, impact, and recovery for community-based organizations in Colorado. And these are just a few examples. There are other states as well, either in the process of getting funds for their individual states, waiting for signatures by governors. So that's an ongoing process, and I'm sure we'll see more. And finally, some other sources, and I've only listed a few of these, but you can see there's large numbers of large money being made available by, for example, foundations and corporate funds to help in the communities, any place, Wells Fargo, Sony, Visa, Mother Cabrini. They're primarily focused on nonprofit organizations, but places to get money. Also, here's some more: United Health Group, Robert Wood Johnson, Lilly, Pepsi, PepsiCo, AbbVie, and the list is really extensive. So there are a lot of places where the foundations and corporations are coming up to the plate to help. And I'm going to now pass this over to my colleague Julia Ryland, who will continue the discussion. Thank you.
Thanks, Denise. Well, thanks everybody for joining us. We have one final piece left to cover here. We're going to turn now to talk a little bit about the public health system's response to COVID-19. Of course, as we're thinking about some of the, the regulatory and legal developments that we're experiencing right now and the economic impact, all of this, it's directly related to the virus and the pandemic that's happening around the world. So to know where we're going in the next few months, we need to take a step back and think about where we're at in the public health response, where this is taking us, and potentially how that's going to impact future legislation and regulations that we're going to be having to encounter. So as I'm sure everybody knows and has heard at this point, there's been so much news and so much going on in the media, but just to take a step back, COVID-19 is the first pandemic known to be caused by the new coronavirus. So in the past century, there's been 4 pandemics that have been caused by the emergence of new influenza viruses. So when we're thinking about data, most of the research and the guidance around this pandemic is specific to influenza. So just keep that in mind. Early on, the patients in the epicenter of the outbreak in Wuhan, China, had a link to large seafood and animal markets, but now what we're seeing really is community spread. So there's this evidence of person-to-person spread happening. It's moved beyond the source. Generally speaking, when you're thinking about a public health response, there's a series of phases that this goes through. There's an investigation phase, followed by recognition, initiation, and then acceleration. The key point to know is that the peak illness occurs at the end of the acceleration phase and is then followed by, a deceleration phase during which there's a decrease of illness. What's challenging in our world right now is that different countries are, of course, in different phases of this pandemic at any point in time. And that's true even within countries. So here in the United States, we have different states that are in different phases of the pandemic, which really is creating a sort of disjointed public health response across the world. So we're having to do a global response. Within that, countries are doing their own federal initiatives, but then states are really having to be very specific because what their citizens are experiencing may be different what neighboring states are experiencing. So this chart just shows the spread of the virus globally. It's a little challenging to see, but 2 points for you to just to take home. The emergence, of course, was in the Western Pacific, and it shows the timeline of how this virus has spread across the world, and then just the sheer increase of cases as it's been exploding here. Generally, when you're thinking about the global response, the World Health Organization is the leading international organization that leads these efforts. They're coordinating with a lot of other global partners here, so there's a lot of cooperation happening. The global efforts, though, we're experiencing a lot of challenges just simply because of the impact. So health professionals are trying to battle this virus and they're putting their own lives at risk. Governments and industries are having to work together. Individuals, of course, are having to stay at home and do their part. So it really is all encompassing. I'm going to go back here. So this just provides a little bit of background on the World Health Organization's strategy in terms of this response. There's set objectives which generally involve interrupting this person-to-person transmission that I talked about, identifying, isolating, and caring for patients early, reducing transmission from the animal source, and really just sort of doing some of this contact tracing to prevent the spread around the world. Of course, we haven't been very successful because now it's everywhere. But there's a lot of different strategies that are undertaken to kind of, it's a complicated method when you're thinking about something of this global nature. On the global scale, countries do begin with similar trajectories, but then diverge based on their individualized public health measures that are put in place. This is a great slide and visual that just really visualizes this. So you'll see it's maybe a little challenging, but one example is we have Italy, who after more than 2 weeks of a national lockdown started to see the curve of this virus flatten a little bit. South Korea, who's the green line sort of at the bottom there, had the most aggressive public health response. There was a huge focus on testing and contact tracing, mandatory quarantines were put into place, and ultimately that sort of aggressive response improved South Korea's ability to sort of flatten this curve. I'm sorry to say that the US is this blue line that sort of spiked the highest. Cases and deaths are accelerating rapidly, even despite some of the public health measures that we've put in place. And the impact is really varied across state lines. So we're going to talk a little bit more about this. So the US now has the highest number of confirmed cases in the world. All 50 states have reported cases of COVID-19, and this includes cases that have been that have occurred through traveling, have spread through contacts or family members, and then just purely have spread through communities. All states at this point have reported some level of community spread, so we're beyond just that travel spread that we were initially seeing. The Center for Disease Control and Prevention, CDC, is the leading national public health institute that's managing our national response. We've included a couple highlights of what the CDC response has been here. So there's of course been an incident management system team that's been established. The CDC has issued travel warnings and guidance. There's been clinical guidance that's been issued. The CDC has deployed multidisciplinary teams to support state public health measures, including case identification, contact tracing. But perhaps most importantly, the CDC has been in charge of developing a test for the pathogen. So we're going to talk a little bit more about testing too. So there's some challenges here to the global response. Recent data has indicated that asymptomatic cases are really a driving factor for transmission. We're seeing data that's demonstrating between 20 to 50% of cases are asymptomatic or pre-symptomatic, which really is sort of changing the public health response to this virus. It means that countries that have a limited amount of confirmed cases could still have significant transmission. It also means that we're envisioning there being a sort of secondary peak or a resurgence of this virus, perhaps in the fall. And it's changing the solutions and the way that we're thinking about how to combat this disease. Social distancing really is going to be one of the most important measures that's going to be put in place, particularly when you have asymptomatic cases driving the spread as we're seeing. It also means that there's going to be a really large importance of antibody blood tests, which is the best method for detecting asymptomatic cases. Another global challenge is just quite simply the inadequate supply of personal protective equipment and testing. So we're seeing a huge issue with that. Also, when we're thinking about pandemics and viruses, we often see that there's a negative association between temperature, humidity, and transmission. And there was early data that suggested that would be the case for this COVID-19, that there would be, a seasonality impact where we would see a decline in the virus when temperatures cool. But more recent data, unfortunately, is suggesting that climate will have little impact on transmission, which means that public health officials cannot rely on decreasing temperatures to sort of help curb this virus. There's been some challenges in particular with the US response. In particular, we've generally been pretty slow compared to other countries to implement preventative measures. We've also had a lot of issues with testing. So testing in the US began back in January at the CDC and was then expanded to state and local public health labs and then private labs. But the public health labs, of course, were not designed to handle the large amount of volumes of testing that we needed. Really, only commercial labs can do that. And the problem is that the rollout to commercial labs was dramatically slower. The federal government didn't issue guidance allowing commercial laboratories to do this testing until the end of February. And unfortunately, when the CDC did send testing kits to states, the initial tests had flaws in them themselves. So there were some issues with faulty testings. We're still seeing data that suggests that the tests have a really high false negative rate. So we're seeing that the tests themselves aren't very accurate, which of course just impacts the reliance of the data that we're having here. There's still a critical shortage of supplies and kits in general. And we're also just dealing with the surge in demand and the challenge that this is putting on the healthcare system. So thinking this through a little bit, when we're thinking about the public health response and looking forward, where we're trying to foresee what's going to happen for providers in the next few months. There have been discussions about an interim bill, and this, it's been happening this week. And the goal was to address the new Paycheck Protection Program. There was generally bipartisan support for allocating more money to small businesses. And on Tuesday of this week, the White House requested an additional $250 billion for this program. Generally, both parties supported it, but what happened is that on Thursday, just yesterday, the Senate adjourned with no deal after a stalemate. We had the Senate Majority Leader Mitch McConnell, who was focusing on, the $250 billion to small businesses. Democrats were hoping to see that, but in addition, also see more monies for hospitals and local governments. And each party stifled the other's attempts to get that passed. So we don't have an interim bill yet, but we do foresee this happening on the horizon. There's also a lot of talk about a second CARES Act. So both members of the parties agree that even a larger package of legislation is needed to address the faltering economy and health effects of the coronavirus. Some provisions that are being talked about are, for example, proposed hazard pay that would go to essential workers that include up to 25,000 increase in salary. There's also discussion around healthcare recruitment incentives of $15,000. So those are being talked about, and we're expecting to see in a few weeks, the fourth coronavirus bill. There's also been a call for immediate relief and support to physician practices. So this is something that we're hoping to see improvements on. One of the criticisms of the federal funding supports is that it assists hospitals, but really leaves physician practices and other groups that are fighting on the front lines out of this. The American Medical Association issued a letter on the 7th, which was signed by over 100 additional physician organizations. And this letter really just called on some of the hardships that physicians are facing. You know, we're seeing physicians that are forced to stay in hotels or renting apartments just to protect their loved ones and maintain social distancing. We have physicians who practice in offices or ambulatory surgery centers that aren't able to see patients in order to preserve medical supplies for those in need of COVID-19 services. Small practices in particular are really vulnerable to financial issues because they have, you know, less access to capital and are operating on thin margins already. But then we're also seeing large physician practices and faculty plans that are facing financial difficulties because they're ineligible for these small business assistance fundings that's in the CARES Act. So across the board, we're seeing physician practices that are grappling with decisions like whether to lay off staff or physicians due to lower revenue, yet also being tasked with preparing and responding to this surge in patients that we're expecting for COVID-19. So what this letter, what the AMA is proposing is that HHS provide immediate funding through this, you know, funding that was provided in the CARES Act to physician practices. And the proposal is that the funding would be tied to 1 month of revenue for each physician, nurse practitioner, and each physician assistant that was enrolled in Medicare and Medicaid. Basically, the suggestion is that HHS use the individual's average monthly payment from October through December of 2019, and then sort of extrapolate that to account for the fact that not all practices exclusively see Medicare patients. And so, you know, theoretically, if a practice or a physician if the patient volume was 35% Medicare, you would take that average monthly amount and times it by 3 to account for the full revenue. We're expecting to see some developments and some response to that letter. Next slide, please. There's also talk about greater push for funding for rural providers. So there's concern that the $100 billion that was provided, the CARES Act, is not going to be distributed equitably to small rural hospitals, critical access hospitals, and other rural providers. So there was a bipartisan group of senators that have been urging HHS to consider these needs and sort of distribute those funds a little bit more equitably to rural providers. But ultimately, what we're going to be doing is just reading the tea leaves. We're sensing, and everybody is in the same the same boat at this point. But our industry has changed rapidly, and we do not expect that to necessarily go away. Some of the things that we're grappling with right now are really going to just dramatically change the way that healthcare is provided and the way that it's regulated in the future. As Jesse mentioned, we're expecting to see an increase in telemedicine even post COVID-19, which means this is just simply because practices that did not historically provide telemedicine are now have been forced to provide it and equip themselves to do so. And then perhaps following, you know, the control of this pandemic, will just continue to offer these services. We're also expecting to see some permanent regulatory changes that will further support the provision of telemedicine. Hopefully with that will include the lasting changes to telemedicine reimbursement. We're also expecting permanent changes related to workplace sanitation, potentially increased flexibility for sick leave, and also potential for decreased regulation in other areas. One thing that's been talked about a lot is this requirement that physicians hold licenses in each state that they practice. There's been a lot of discussion about whether that's something that should just be removed entirely. Overall, though, we're also unfortunately just going to simply see some marketplace changes. We may see some providers drop off the map just because they're not able to handle all of these economic hurdles that they're being forced to encounter right now. We're also likely going to see, you know, a boost in other providers. So we may see a boost in pure telemedicine companies following COVID-19, and it's really going to sort of shift the marketplace as we see it today. Next slide, please. So we wanted to be sure to leave some time. I'm going to end it there. We wanted to leave some time to make sure that we're answering any questions that you all have. Feel free to ask them in the chat window here. Jesse, I think you've been tracking on some of the questions, so I'm going to turn it over to you and you can walk us through if we have anybody that wants to talk about any points in more detail.
Okay, great. Thank you so much, Julia, for that. And thank you, Randy. Thank you, Denise. That's a lot of super helpful information for folks. So if you do have questions, feel free to submit them. They will come into the chat room and I will read them out and we will try to answer them. If folks don't feel comfortable doing that and you want to call or email any one of us after the fact, you are more than welcome to do that as well. Our contact information is up on this slide here. And just so you know, I believe tomorrow we will have this presentation, which includes the slides themselves, along with a recording of all of our comments up on the website, which you are free to use and disclose, to use HIPAA parlance. Little joke there for the HIPAA aficionados, as you see fit. So, okay, with that, questions. So one question that we have is about retroactive coverage for telehealth services. And yes, the payment rules for telehealth under the Medicare program are retroactive. They are retroactive back to March 6th is when that standard kicks in. Another question here related to telehealth is asking about the type of communication tools that a provider is supposed to be using if they want to provide services via telehealth. And so I will take this one. This is what I was mentioning before. This comment about smartphones or other devices being used for purposes of providing services and getting paid for telehealth. And so the issue is that you have to remember when Medicare started paying for telehealth, they began rolling out the policy materials, I think in 1998 and 2000. So, you know, ancient, relatively speaking, computer systems, technology, systems, and the guidance talks about telecommunications technology that has audio and video capabilities that can be used for two-way interactive communications, but it's something that folks have struggled with in the past. And what the new comments say in the interim final regulation that came out basically is that the types of devices that we are all using for our kind of day-to-day activities on our jobs, smartphones, iPhones, things like that, will make the grade for Medicare reimbursement purposes. One thing that's related to this principle that's kind of interesting is, you know, this issue of, well, okay, you're using your personal device to start communicating back and forth with patients. So how does that work under HIPAA, for example? The HIPAA security rule requires healthcare providers to you know, conduct a risk analysis and have appropriate safeguards designed to maintain confidentiality and integrity of electronic protected health information. Encryption, for example, is a recommended safeguard under the HIPAA security rule. So how are we, you know, able to use these devices for purposes of telehealth payment during the midst of this emergency? And what the Office for Civil Rights said relatively recently on this topic, and I think they may have done that in the context of either a frequently asked question or perhaps a policy statement that was up on their website, was they would waive their enforcement, they would waive penalties and exercise enforcement discretion during the midst of the crisis, so providers would be free to use those devices for you know, communicating. And I believe they even mentioned specific products like FaceTime and Skype if I recall that guidance. So OCR has tried to do a few different things to make the requirements under HIPAA a little bit more manageable during the interim. Another question that has come in that I think is probably for Randy would be, you would be the best bet for this one. Randy, do you envision any kind of revised or new paycheck protection program being rolled out in the near future, or is that not something that's likely to happen, would you say?
I think they're going to expand the pool of funds available under the program because there were so many applicants and so many people in need. I also think that we are continually seeing the government loosening the rules with regard to who can qualify, how you qualify. I believe there's also going to be something done on this affiliation rule, which is causing a lot of problems with people who are have equity fund investors that help operate the organization. So I think we're going to see more development and expansion of this program going forward. Let's just hope that all of a sudden the virus stops and the government shuts it down. That's the best thing we could all hope for, so long as there's enough money in the system to keep everybody going.
Yeah, I agree with that. Another question, and so this is about the Public Health Social Services Emergency Fund and our $30 billion that's being paid out today. This question is about types of terms and conditions that need to be met. If you are a provider and are going to take that money, what are you agreeing to? It's kind of interesting. You're cashing the check before you know what you're agreeing to. I did mention you do have the opportunity to give the money back. I recognize that might be challenging in these circumstances, but that is available. I think it's within 30 days you need to do that. But as far as the terms and conditions themselves, it's interesting. The point I mentioned before about the sort of in-network versus out-of-network billing, this question of surprise billing that the current administration has been talking about. It's also been a challenge, going back just to the creation of differentials between hospital-based and freestanding reimbursement, and the fact that patients get charged more in a hospital outpatient setting. And then this question of, if you're seeing someone who's out of network at a hospital, you didn't know that the radiologist wasn't in your network, and you get this bill and it's much, much more than you expect. Patients are concerned about that. And so the big term and condition for the $30 billion has to do with the out-of-network billing. But there are a number of other provisions in what HHS put out today, and they're interesting because they may be a little bit off topic as far as what folks think are likely to apply, but it's basically provisions that come from various federal statutes that restrict using the money for specific things. Lobbying, for example, paying the salaries of executives would be another thing, funding for abortion, or I think even gun control advocacy. All of that is sort of baked into this set of terms and conditions that providers are agreeing to. So if you're interested, I think it's about 10 pages. If you can't find it, let us know and we'll get it to you. But I do encourage you to take a look at that. Okay, another one, okay, again, this one's probably for Randy. So, and this one's pretty specific, but I will put it out there. So I have an employee who would like to retire on May 15th. Am I going to be penalized under the Paycheck Protection Program loan programs due to not paying her since she retired?
I don't think you're going to be penalized for that type of situation because the aberrations in the system could be horrific. I think the government's going to allow you to certify that the reason for the reduction in staff was a retirement or a natural transition. That's part of the reason why they're using the averaging techniques. You know, you can exclude employees from the computations altogether who made over $100,000. So, and there's no regulations that have really come out yet, or guidance that have come out on how you implement a formula to determine what the number of FTEs are in a given day with all the different exceptions that are under the law. So at the end of the day, I do not think that the government is going to be punitive on anybody who's acting in good faith and making a good faith approximation of who they have. And I've been telling my clients that if you believe that you're in some type of situation that doesn't fall neatly within the rules, to the extent you're making an attestation or a certification to a lender, make sure you have a full disclosure of what it is and why it is. And even though it's your responsibility as the borrower to comply with the rules, I think it's going to end up, from what we've heard, depending upon whether people are acting in good faith with regard to how they're approaching the program and how they're making their reports. So I can't imagine that they're going to penalize people. If there's, now what you can't do, of course, is lay off a whole bunch of people and say that half your workforce decide to retire, you know, and most of them are in their 20s. I'm being a little facetious there, but you have to do what's in good faith, but I think you'll be all right.
Okay. In this one, I think we probably have time for one more. Denise, I think this one is probably for you. And this question is saying, you know, I've heard about a lot of different Medicaid waivers and like the 1915 waiver, for instance, and also Medicaid enforcement of survey activities. So can you say anything about what you think Medicaid agencies might be doing with respect to surveying health providers for compliance with various requirements?
Yeah, a lot of the surveying has been really limited by solely looking at just complaint survey issues. The routine surveys are pretty much being put on the back burner, and I think that's going to continue because the real emphasis is just being placed on getting the services for the patients that need them. There's the waivers, I think, are going to continue to be coming in terms of requests, in terms of other modifications. And it's been moving so rapidly, and really pretty much daily waivers are being issued. And just looking at what the history's been up to this point, I think we're going to continue to see the emphasis focusing on getting the services for the patients that need them and helping to make sure there are enough providers to do that.
Okay, well that makes a lot of sense. All right, well with that we are at 1:30, and we certainly want to be respectful of everyone's time today. So thank you so much for taking time out of your day to participate in this event with us. We really appreciate that. As I mentioned, the materials will be available on the Lathrop GPM website tomorrow. You are welcome to contact any one of us with any questions you might have. If we, for instance, did not talk about something that is important to you, please don't be shy about reaching out. And I just want to say thanks to my colleagues, Julia, Denise, and Randy on this call for taking time to participate as well. So with that, thank you for attention, and we wish you all a terrific day. Goodbye.